Okay, so this rant is on unnecessary complexity in the past history. You see GP summaries and they're just all over the place, which is not necessarily their fault. It's often the software that's been developed for them, which is the problem. But the commonplace thing is that you have a complex patient with often quite a vast list of past history and a list of medications in no order. And it's incredibly difficult to wrap your mind around what's going on with the patient. So if you're inheriting this patient in a hospital or in the intensive care unit or in the anaesthetics bay or in the physician's rooms and you're trying to work out, or if you're a GP and where your partner is on holidays or you're locuming or something like that, you're seeing this patient, there's this whole list of information. You've got to try and work out what's actually going on with them. So communication is vitally important in medicine because stuff gets lost and forgotten and it can come back and bite you. So it's actually really important that we simplify these things and just take out all this unnecessary stuff so that at least you can try and visualize and encapsulate what's going on with the patient. Um, Chronological ordering is just a disaster because it doesn't mean anything. The time elapsed since onset is rarely of great importance. Um, uh, Perhaps hypertension and diabetes, it's important how long a patient's been had that diabetes, had those illnesses for. Um, as you can see, come on, machine, come down. I'm not a fan of alphabetical lists of medications um, because you severity score somebody by saying how many medications they take. If somebody's on 8 pain medications, then they're obviously pain is a significant problem for them, and it may be a specific problem for you depending upon what their new presentation is. If they're going to have an operation and you're the anaesthetist, you're going to have trouble dealing with somebody who's on 8 pain medications. So at least grouping all of those medications together by their therapeutic class rather than by the letter of the alphabet that they begin with makes some sense. Um, yeah, there's apathy about the degree of complexity in modern medicine, which allows all of this stuff to go on. I don't know whereabouts in the world you are, but there's a sloppiness about how this stuff is dealt with, and we need to start becoming a bit more ordered and organized in the way that we think about these things. All right. Pardon me. So, in the past history, the one-offs are the things which have been and gone. If you've had your appendix out, it's rarely going to come back and haunt you, especially once you're more than 6 months or 12 months down the track. If you see bowel cancer written down and somebody doesn't put a time on that, then that makes it really difficult to know, is it something I need to worry about? Is it something that's going to come back to haunt them? If it was a month ago or a year ago or 10 years ago, makes a big difference. So putting timings on things is incredibly important. Um, um, a lot of the surgical stuff, once it's been dealt with, is fixed, which is one of the good things about surgery. It tends to be a fairly black and white sort of problem. If something's disappeared into the distance, it's unlikely to come back and cause problems. Medicine's more complicated than that, um, but you've obviously got the acute illnesses and the chronic illnesses. The acute ones cause acute problems, but the fact that somebody's had pneumonia 15 years ago, unless they've got a complication of that pneumonia, like bronchiectasis or an empyema that needed draining or something like that, it's probably not that important. Well, so it isn't that important. And it should be either right down the bottom of the list or the fact that they had pneumonia once before, who really cares? If they've had 3 sets of pneumonia within the last 2 years, then I'm actually interested because there's something going on there. Have they got an endobronchial lesion which is obstructing um, their lung, if they're getting pneumonia in the same area, then that's important. Do they have an immune disease, an immunosufficiency? Are they on steroids? Those sort of things, which is sort of important. But a lot of the acute medical ones um, aren't going to cause you that many problems. The chronic diseases you can divide into the more minor ones which tend to be in the background sort of diseases. They can mess up the quality of your life, but they're not going to kill you, I guess is the important thing. They can certainly mess up the quality of your life. I've got a friend with rheumatoid arthritis who's steroid dependent, and she doesn't have a great time. She got addicted to opiates at one stage because of the problems, but it's not going to kill her unless the opiates do. She's off them now. You'll see in some of my other videos, hypertension, hyperlipidemia are not really diseases. They're risk factors for other diseases. Diabetes is another one. So unless you've got an acute disease related to your diabetes, it's more the fact that it's a risk factor for the chronic vascular diseases. So this is the way that I write out the risk factors, because they're cumulative. If you've got hypertension and hyperlipidemia and diabetes and you've been a smoker and you've got a bad family history, you're in trouble. I then describe the complications in each vascular bed, so the cardiovascular diseases, and then, you know, the vascular diseases are sort of interesting, but somebody can have really severe arterial disease, coronary artery disease, but if they don't have any heart failure, then they'll be going okay. It's the heart failure that kills people. Whether they need a AICD, a defibrillator, whether they've got a pacemaker, what's their renal function like, what's their cerebral function and their peripheral vascular vasculature like. So you can see how you can take a whole heap of diseases on that list of on a GP's list, and you can actually put them all into one one area. And when you put them all together, you can see that this person, I mean, this person's had a non-STEMI and a STEMI and 5 bypasses, and they still get an angina. They've got a defibrillator, they've got a pacemaker, they've got atrial fibrillation, heart failure. We don't know how moderate heart failure. So this person is probably, I think it'd be reasonable to say that they're a severe vasculopath. They've got a really crappy heart and they've already got significant heart failure. If you get admitted to hospital with heart failure, 50% of people are dead within 12 months. So having moderate heart failure is a bad prognostic sign for this person. We should gather all of the respiratory diseases together so that you know, have they got asthma, have they got COPD, have they got both? Asthma can cause COPD if you've got neutrophilic asthma. That actually releases enzymes which dissolve parts of the lung. Eosinophilic asthma is less of a problem for that. But if somebody's got asthma and they've developed COPD from that, then that's important. If you can put all of the all of the bony diseases and the orthopedic procedures and things together, it gives you a way to assess their mobility, because ultimately that's what we're looking for when we're looking for the past history, the complexity of the past history. What we're trying to do is to be able to nut out how good or bad is this patient's. Are they good protoplasm? Are they poor protoplasm? Have they had lots of problems in multiple organ systems? So in summary, you want to put together, pardon me, all of the chronic diseases. You want to include frailty because it's a marker of morbidity. Then you can a coherent list of medications, which allows you to severity score these illnesses, and then you have a coherent past history. When you can say that they're a severe vasculopath with moderate heart failure, moderate renal failure, it tells you a lot about the patient, and you've taken a big long list of diseases and you've shrunk it down into something where you can say it in just a few words. That's where you get coherence. That's where you get elegance when you're presenting this to one of your colleagues or one of the consultants, or if you want to get tests done, if you're talking to the radiologist and you can say what's going on with them and why you want the test. The fewer words that you can summarize something in, the easier it is for you to get your ideas across. Okay, I hope you like that.